Moving forward from introducing economics and healthcare economics, let's look at how health services are evaluated and function as a market. Again, I am Professor Gonder, or Dr. Gonder, Christie. This is the second lecture presentation for the semester. My LC email is located here on the first slide. If you have any questions, email or call anytime. I do my best to get back to you in a timely manner. There is also the Q&A discussion forum that I encourage each of you to use to help each other out with general questions, course tips, etc. This lecture presentation details how economists evaluate healthcare or medical care, and then we will look at examples of what creates a demand for medical care, and subsequently, the need for health insurance. In the course, I copied a link to short lectures given by renowned economist and professor Dr. Thomas Sowell. Refer to that ad lib. I like how he explains the various topics. It consists of a 9-part lecture series. Very doable. There are ways to evaluate, or as a healthcare professionals, we could even say assess health economics. Recall the 10 key economic concepts. They apply here as they do throughout the chapters. When it comes to healthcare, we cannot overlook the fact that we are still dealing with scarce resources, despite the urgency and value society places on healthcare. And this manifests even more so in growing societies, right? More people equal more healthcare needs, more demand. But demand does not magically create supply, nor is there an endless faucet of money to fund healthcare. That includes overhead costs such as payroll, nurses and radiology salaries, basic costs to keep the hospital running like lights, plumbing, medical supplies, laundry, and biohazard waste disposal. Naturally, we start with the disease or health condition itself. Is this a long-term chronic illness or short-term acute? What are the implications? For instance, type 2 diabetes versus a fractured arm. Of course, those costs differ quite a bit. Moreover, when we lose functionality, whatever that may be, we're also losing leisure and the consequence of pain and suffering. There is a term relevant here, willingness to pay. This refers to how much money people are willing to pay for small reductions in the probability of dying. Can you think of an example? A good one is the choice to wear a seatbelt. Cost-benefit analysis is another economic concept that applies in nearly every decision we make, even to our own daily lives. One could pose the question, what is the return on my investment to go to nursing school or to go back to school for a bachelor's degree? What is the cost-benefit? In other words, is it worth it? We ask the same with healthcare utility. Two primary approaches to evaluate healthcare, really how we place value on life, are based on the human capital way or the Karl Marx exploitation theory. Capital way is often used in medical lawsuits. Human capital way looks at the monetary value of life. It equates the value of life to the market value of the output produced by an individual during his or her expected lifetime. Factors that go into these decisions include age, gender, lifestyle, education level, and current or anticipated future career. And of course, we look at what the injury caused. Is the individual now a paraplegic versus the presence of a skin rash? Likewise, if the injured is, say, a 60-year-old, that would not carry the same market value or income potential of, say, a 19-year-old. Take Y, income, over each year. Evaluate future income to get an estimate on the value of the person's life. How much deprivation in future income has occurred? Is there negligence? If negligence, is it your loss or the organization's? i.e. malpractice. It reflects earnings. Karl Marx basically infers survival of the fittest. It's based on work and output. If W, work, is less than O, output, your human capital quality goes down. Karl Marx believed people are poor because they choose not to work. Cost-effectiveness analyses essentially answer, are the outcomes supported by the costs? We could go back to diabetes type 2. Are the costs associated with the outcome? Here we can look at neuropathy or dialysis rates and compare to the average individual costs associated with medications, insulin injections, and other comorbidities associated with DM type 2. Economists take cost-effectiveness studies and look at some particular end to select an alternative to achieve the most effectively. It really depends on where you sit in the Y or income distribution. If low earnings, you may be left out. Therefore, as I have stated here, universal coverage and access infer all participate, which we all know is not the case. Healthcare is predominantly subsidized. Those who may not use or use very little pay for those who do. A basic noteworthy equation is TR, total revenue, equals P, price, times or multiplied by Q, quantity. So profit equals TR, total revenue, minus total costs, TC. Case studies. Using these common scenarios, apply the concepts well. I mentioned the type 2 diabetes example. We often advocate for various health screenings, immunizations, and medications. Whether as a preventative measure or to treat, these are examples of choices we make for incremental reductions in poor health or an early demise. You can read up on any number of these studies, from cancer screenings, cardiac interventions, etc. Remember, not only are costs considered, but the QOL measures. If, say, cancer screening reduces the prevalence of a particular type of cancer, great. But if it's looking at lives saved from aggressive chemotherapy, is that number quantity remarkable if quality of life is diminished? That is nausea and vomiting, fatigue, muscle loss, or medications for Alzheimer's disease or dementia, yet there remains no cure. There are those circumstances, too, where a trend in population practices forego options regardless of effectiveness, such as today's HPV vaccine and the COVID mRNA vaccine. So taking the case examples, we can apply in terms of direct, indirect, and intangible costs. Again, there is the quality versus quantity of life, value versus years. The intangible is what we talked about in the first few weeks of class that makes healthcare, HC, often different from other commodities because healthcare is not necessarily seen. There's no physical product, unlike purchasing a car, furniture, clothes. Insert your own example. What comes to mind? It may even be those unforeseen emotions associated with illness, pain and suffering. I needed what I call an expensive auto mechanic. Had 2 heart valves placed via open heart surgery. Walking around, no one would know that. Heck, I don't. I still can get winded walking up a flight of stairs. But with that surgery also came lost work time and the emotional manifestations associated with recovery. Like anything we set out to do, we consider time and efficiency. What can we do to ensure effectiveness and maximizing for the greatest number of people? Throughout the book, statistical data are used to highlight economic outcomes. Data don't lie. Well, maybe. I think it was Huck Finn who said statistics are lies, lies, and more lies. Numbers, quantifiable data, demonstrate outcomes. whereas qualitative data show us the values-based feelings research associated with the disease. This may be the effects of pain and suffering and the emotional toll the medical condition has on the patient and his or her support system. Nurses are commonly attracted to the latter, to qualitative research studies, because we care about the effects of health, the LIA, lived experience, versus the corpor, biomedical, physical metrics. Now, both are valuable. Therefore, you will hear probably, hopefully, in every single class to look at the evidence. Formulate an opinion based on an informed decision. With that is the quality of the research. Instead of pulling from a news commentary or what an acquaintance posts in social media, pull the original article. Is the authors credible? Were data gathered ethically and analyzed using credible statistical software analyses? What were the implications or generalizations posed by the study authors? Did they try to claim the findings apply to everyone? No, immediately throw that out, because not everyone realistically will be affected, not even those with the same inclusion criteria or eligibility. Ask, what is the endpoint? Economists care about everything that goes into the equation, all measures to link the health outcome to treatment options. Here we may consider the opportunity cost. What do you give up for the alternative? Exchanging one medical intervention for another, perhaps. A good old decision tree does well. So considering those indirect and intangible that are so prevalent in health and healthcare, what do you suppose are examples of direct costs? I'll give you a minute to read the question and choose the best answer. All produce direct tangible costs except loss of productivity. Answer C or D. Yes, one could argue your paycheck may go down, but it is difficult to measure productivity. You could be on the time clock but take frequent breaks or omit completing certain tasks, or there is lost time due to sick calls, PTO use. Okay, so let's revisit health. Recall, health and healthcare are not synonymous. They are often used interchangeably, but are not the same. Similarly, need and demand are not the same. Health is subjective, very subjective. It is about one's well-being. So kind of like measuring work productivity, how do we measure health and the production of health? Health is a product of healthcare. Healthcare is one aspect of health. It's not its determinant. Therefore, health is a function of healthcare, everything else being constant, so we can measure its effects, good versus poor health. What comes to mind for you as an example of some health circumstance that we can see its effects? Measurable. I think of the effects of morbid obesity. Oh my gosh, that affects so many things, one's physical and mental health and overall well-being. Economists naturally approach it as an input-output equation. What is the relationship between health and the factors that manifest health? Good health. This is the health production function. Also combines the time factor. Again, what are those things each of us take or do to improve our lives? What is the investment in our health? Moreover, what is the maximum point by which we may model good health based on what has been spent to get there? Remember, the elasticity of healthcare has values between 0.1 and 0.15. So if a 10% increase in healthcare we only get a 1% increase in health. Consider 2, maximum utility. There is not an infinite amount of healthcare. We can assess using the flat of the curve argument. This infers that we consumers pretty much use what we need. At the top of the curve, we cease to go further. This is true about that favorite candy bar, cold beer, latte, even healthcare. It may seem silly, but think about something you really enjoy. At some point, you've had enough, at least in that one sitting. What all this tells us is that healthcare has little effect on health. Health is individualized and multifactorial, guided by personal preferences and beliefs, such as time and the perceived future payoffs, genetics, such as predispositions to disease and illness, lifestyle, socioeconomic status, such as income, environment, such as living situation, and gender. An example here is pregnancy and medical care for labor and delivery. And what are the available alternatives? Never overlook those individual or patient factors. Essentially, we will do what we want when we want, with or without all the healthcare in the world. Those of you already working in the field know this to very much be the case. The smoker who will not quit, the diabetic who will not change his or her diet, the obese who will not exercise. You get it. Now, this does not omit physician factors. We, individual patient, is the principle that permits the agent physician to trust their decision on which treatment we need. So why or who insures? Factors affecting the demand for health insurance include 1, price, 2, the probability of being sick, 3, employment status, and 4, average income. Now you could be thinking, hey, I thought the ACA requires that everyone has health insurance. You would be correct, but since the mandate portion of the Affordable Care Act occurred through executive order, President Trump eliminated that, which kind of unraveled the ACA because the mandate ensured its funding. Now, even when the mandate existed via President Obama, people still had a choice not to insure by paying the penalty, which was a small nominal fee. Not many know how that fee was collected. The fee was structured in a way that it was withheld from one's federal tax return. If you happened to already owe or broke even, there was no way to collect the penalty fee. And obviously, there were no criminal charges, so you couldn't be sent to jail over it. Now, why choose not to purchase a policy? Why would anybody at any time choose not to have health insurance? We fall into one of 3 camps when assessing risk and the demand for health insurance. A, risk averse, B, risk neutral, and C, risk seeking. Risk averse refers to those who believe the risk of loss is greater than the gain. The gain being knowing there is insurance when and if you need it. Most of us fall into this camp. We feel secure with that safety net. Those who are risk neutral are like, whatever. Insuring is like a 50-50 gamble. Can go either way. But they don't place a lot of time or concern over it. The risk seeking is what I think of as the daredevils. Those who bungee jump, drive a motorcycle without a helmet, you get it. But really what this term conveys is that these individuals take the risk of loss in favor of the gain. The gain is the money saved from choosing not to pay for a policy for the possibility that an event may occur. The risk neutral and risk seeking typically do not insure. Besides the risk seekers, which kinds of people fit into which category of risk perception? For one, it is important to understand that just because someone is not insured does not mean he or she can't afford it. The risk neutral or risk seeking are often seen among the young adult male who has little to no health care needs. Health insurance becomes the payer, what we call the third party, because they mediate and thus influence the cost. The consumer rarely pays the actual or sticker price of the health care. The insurer negotiates price structures, which includes accounting for nursing care hours and other overhead expenses. Two key considerations for the costs associated with a healthcare policy include adverse selection and moral hazard. Adverse selection occurs when the policy consumers are viewed as equals across the health spectrum. This creates a disproportionate risk pool. More people than expected are using the insurance. In this case, you can see why the 25-year-old male chooses not to join his employer's health plan, because he is paying premiums as high as the 50-year-old diabetic coworker. Moral hazard occurs when the consumers alter their behavior because they are insured. Perhaps become more risk-taking since the out-of-pocket costs are low. We can all relate to this because it is innate human behavior. We go to the urgent care if it costs us only a $25 copay instead of the full, say, $300, right? Here we see what a low price does to demand. In fact, the third-party payer structure is so prevalent in the states that often even the providers couldn't tell you their fees. Ask your doctor next time you go in. Due to the excessive billing and overhead costs, they really don't know. Now, we are starting to see a shift in this. Doctors are either joining large hospital systems like Providence or St. Luke's to simply be a salaried employee, or those in private practice privatize, if you will, their medical clinic, where they provide a cost list and you, the patient consumer, pays for it, whether you pay outright or set up a payment plan. But there is no insurance involved, and therefore it eliminates the bureaucracy, the regulations, and overall burden of cost negotiations. Some claim this has improved the one-to-one relationship between physician and patient too, because it not only promotes individualized care, but there is no need to submit to an insurer for approval. Okay, back to definitions. This poses a moral hazard because it creates a moral issue. People take advantage of the utility. And while you could suspect that that's kind of like stealing, well, this phenomenon is not illegal. Get into greater detail with the types of health insurance in the next section, but let me briefly introduce the differences in reimbursement since we are addressing costs. There are two types of health policies, private or public. Public health insurance is your government or federal program such as Medicare, Medicaid, and within the Medicaid system, individual state-funded Medicaid programs such as SCHIP, State Children's Health Insurance Program, and the VA, Veterans Administration Health System. The public policies are funded via federal and state taxes and are not limited to just the poor. They include those with mental and physical disabilities and the elderly. We will get into this more later. Private are most often your employer-funded policies like a PPO, Preferred Provider Organization, Blue Cross Blue Shield, which is under the umbrella term Managed Care Organization. MCOs also include HMOs, health maintenance organizations, such as Kaiser Permanente and Group Health, common in our region of the country. Private pay is different than private insurance. These are the individuals, recall, who choose not to insure and may assume the full cost. At this point, I want you to recognize the reimbursement model differences. MCOs adhere to a prospective payment scheme, meaning they determine costs before care is rendered. They reimburse a set amount. Public policies are this way as well. For example, DRGs in the federal Medicare structure. It is cost-based rather than market-based. Hospitals and providers are reimbursed based on the bundled diagnostic related group, DRG. This says that you say get $45,000 for a cabbage, but that's it. Whether the patient has an uneventful 4-day hospital stay or a 30-day stay, it's gaming, really, since not everyone is equal under a DRG. One may be sicker than the other. Indemnity plans are known as your 80-20. Consumer pays only 20% of the cost, but reimbursement is retrospective. Payment is based on utility, therefore pays after the care is provided. So the former is before, prospective, the latter is after, retrospective. Think of retrospective as in retrospect. What is meant by this is that we can look and think about a situation. Retrospective payments help ensure viability, since the hospitals and providers need to meet their costs while still making a profit. Otherwise, they can't keep their doors open. Not to mention their liability to practice remains high. Payment for services and personnel have dropped so much in recent history that this is why we see hospitals closing and providers declining to take Medicare or Medicaid patients. In this case, one could surmise the patient is underinsured since there are limitations to their options. You may think this sounds greedy, but consider if they dropped your wage in the same way. Your liability does not go down, nor do your responsibilities. So naturally, those affected speak out. Remember, neither healthcare is free. This concludes this lecture presentation. As I said, we will get into greater detail about the health insurance market. We will also look at supply side, hospitals and doctors, surgeons. We will also look at our health industries that are essential, pharmaceuticals and the medical device companies. Have a great day and wonderful rest of your week. Bye now.